Right, so the question is, when is local resection a good option for an early rectal cancer? And in fact, out of a surgeon's point of view, we know what to do with early rectal cancer. It is a curable disease. It's a curable disease if we do all the things that Mr. Moran told us just now. If we do a TME, the vast majority of patients will be cured for life. And we know that ever since the 80s and the 90s with this monumental work by Bill Hild. The point is that if we check on this year, this month, low-anterior resection has a quite high morbidity rate. So if you expect from surgery a 28% major morbidity, and add to that the morbidity of the ileostomy closure, then out of a patient's point of view, if you can avoid this surgery and still be cured from cancer, then you should avoid it. More, onto that, you also have bad quality of life. We know that very well, that at least for the first year, and probably for more than that, most of the patients with low anterior resection will have some sort of loss. So if we can avoid this bad quality of life in the future for our patients and still be cured from cancer, then that's what we're looking for. So local excision is one of the possible strategies in the greater objective of curing cancer while preserving the organ. And there are two cases in which local excision might be applied. Now, the first one is the truly early rectal cancer, of which we will be seeing less and less after the pandemic because most of the screening programs have gone a bit south. But also, and more importantly, the regressed rectal cancer. This is the early rectal cancer that had some sort of neoadjuvant treatment and regressed to something much more amenable to local excision. We know which of these early rectal cancers will be cured probably with a local excision, and these are the very early SM1, low grade, no lymph nodes, no vascular invasion, no lymphovascular invasion, probably, of course, no EMVI. But the problem is that we cannot really recognize these patients when they get into our clinic. So we know which patients will totally benefit from local excision, but we don't have all the means to recognize them early. And also, some of these patients, even with the most favorable histology, will recur because even with a favorable histology, a 9% could have lymph node disease. And if they have regressed from something bigger than an early cancer, we know that we cannot be really certain when we excise the scar or what is left from a neoadjuvant chemotherapy because of this tumor scatter phenomenon. We could get a clear margin, we could get a clear biopsy, but still cancer may be somewhere around there and we don't know where it is. For these reasons, even when we know who the patient will benefit, sometimes we get recurrences in the future. So how to best select our patients for local excision? We need to do everything: clinical examination, endoscopic ultrasound, MRI, and biopsy. And I will insist on biopsy because in order to have a strategy of organ preservation, you need to have the absolute total information you can get from a biopsy. You can't go ahead with just a biopsy of adenocarcinoma. You need to be certain that the pathologist has cleared that there is no lymphovascular invasion, no vascular invasion, and of course, go ahead and do immunochemistry because we have different disease. For example, all patients should have an MMR status now before proceeding to anything more than local excision because we have immunotherapy and the results are astonishing. This is last couple of weeks in ESMO. So all these patients have a different disease and should not be enrolled into our studies for local excision and standard adenocarcinoma. So what can we do? The simplest possible strategy is this: local excision followed by early radical surgery in case we have unfavorable histology. And this has been done a lot in the past. This is from Germany, from Mainz. Has been done a lot. And the only problem with this is that you do get a good survival, but you lose a lot of rectums. Because in order to do that, you just go ahead and do no more therapy, no preoperative treatment, no postoperative treatment, and you will remove a lot of rectums, but the patients will do fairly well. They could do very well, actually. So everybody started thinking, what else should we be doing when we have the local excision patient? In Japan, this is a wonderful study. They did a local excision for clinical T1 lesions, and even if they had a favorable histology, they kept on and proceeded with adjuvant chemotherapy, radiotherapy. So this produced a result which is TME equivalent in terms of survival and local recurrence rate. So even if you have a good T1 and irradiate the patient, then you get the best possible results in the long run. You don't get these results if you have a T2 tumor. For a T2 tumor, chemoradiation after surgery, local excision, is not enough. You need to do a TME. And this has been shown in most of the studies up to now. So for T1 and chemoradiotherapy might be enough, but for T2, you need to operate and do a TME. Now, if we try to move treatment before surgery, what can we do? Initial studies, earlier in 2000, you had short course radiotherapy. This study from Italy had to be stopped very early because of unacceptably high morbidity rates. But then, this is the most well-known, the Aguilar study from the States, where patients were actually receiving standard chemoradiation therapy before treatment. They all had local excision, and if they had a T3 tumor, then they would proceed with TME. All others would be followed in the future. Now, this study, this protocol, achieved a 91% organ preservation at 3 years. This is what is called a TME-free survival for 3 years. And this is because half of the patients had actually a complete pathologic response. The problem with the statistics of the study was that the survival after local excision appeared to be inferior to TME. So the authors concluded that we can do that only in patients that are scheduled for APR. So if they're scheduled for APR, and we can give them a try and preserve the rectum and the anus. Same thing was literally done by the French before the major studies with the long course radiotherapy and local excision, and they reserved that just for the high-risk frail patients. So all this knowledge that started accumulating led to some more elaborate studies like the TREC study, short course, or the Dutch CARD study, long course radiotherapy, and TEM, and local excision. All these were feasibility studies, and they all showed that you can actually do that without harming the patient. The most influential, of course, is GRECAR-2. GRECAR-2 is a wonderfully designed study because you have low rectal carcinoma, T2 and T3. You give chemoradiotherapy to all the patients, and if you have a poor response, then you go straight for TME. But if you have a good response, then you randomize to local excision or TME. And then if you have a good T1 tumor, you stay with that and you watch and wait. But if you have a bad T2 or T3 tumor, you proceed to completion TME. According to this study, if you follow this strategy, then overall, the survival and the recurrence-free period of your patients will be equal, even if they have TME or local excision. Plus, many of your patients will have preserved their organ, the rectum. The only problem was that if you needed a completion TME, then the late results would be considerably worse, both in oncological terms and mostly in terms of quality of life. Because if you do a completion TME, then the patients have to face a lot of morbidity and they have to face a lot of definite colostomies. And this is, I remind, definite colostomy for a disease that, in fact, it is early. So if you need a completion TME, then things are probably difficult for the future. Can we save these patients from having a completion TME? I mean, the reason why they have high morbidity is because they have a local excision, they have a scar there, and then you go ahead and do a very low anastomosis on the scar. Now, an answer would be that if we use ESD instead of TEM, which is what very capable gastroenterologists can do, then you get all the information you need without a major scar. So if you have a gastroenterologist that can do this and provide you with a very good specimen and all the information you need to know whether you will proceed or not, then you will lower the incidence, probably, of a completion TME surgery. And we move on to the next concept, and the next concept is this. This is an ARISTO study from Dublin, actually, with the same basic protocol, but the point is that 2/3 of the patients could have avoided local excision because local excision did not add up anything to the overall treatment of the patient. And this leads us to this, that if complete response can actually be determined clinically, then local excision of the scar does not confer any benefit. And this is very important because our aim must be to probably use local excision only as a therapeutic method and avoid all the local excisions that are done just to make sure that we have progressed well with the patients and his treatment. And the future in this, or probably what will be imposed as a future to most of the hospitals, comes from across the Atlantic, because the response you will get and the response that you will have in order to judge and decide what you do with your patient depends largely on the initial histology, but also on two things: how much chemotherapy you will give before the operation, and how long are you going to wait to see the complete response. So with the OPERA study, which is the most influential at the moment in the States, Essentially, if you wait long enough, you increase the number of patients that will have a complete response. And all these patients will not even need a local excision. And so if you wait weeks and months, less and less of your patients will actually require a TME surgery. And this is one of the most important slides. That's yesterday for the Star Trek trial team. This is the most important because now we put patient's preference before the randomization. This really struck me yesterday. Because if you inform the patient and ask him, do you want to go for organ preservation or do you want to get done with one go, TME? So the patient needs to understand that he needs to take some of this responsibility on his shoulders. So if the patient decides that he can go for one stop, that's TME, he could go for TME if he understands the consequences of morbidity and loss. But on the other hand, if he tries to save his rectum and his anus, then we randomize the patients to either short course, long course, chemotherapy, total neoadjuvant chemotherapy, and then there's no end to that because there's no end to studies from oncologists. So in conclusion, local excision is a very good choice for true T1 tumors with favorable histology. Local excision is not sufficient for high-risk T1 or T2 tumors. And the timing of response assessment depends greatly on tumor aspects and neoadjuvant strategy. So the more neoadjuvant chemo you give for T1 tumors, then the more you expect in terms of response. On the other hand, poor responses require complex treatment strategies involving both chemotherapy and TME. Thank you.
Thank you very much for this nice overview. You mentioned the selection is decisive for treatment options like local excision. So regarding a tumor, let's say 3 centimeters or beyond, how do you rate that you are at the correct area to biopsy? You mentioned biopsy is one of the crucial steps towards diagnosis of treatable early rectal cancer cases.
Yes, this is a great question. If with the first biopsies you get a positive result in terms of lymphovascular invasion, then you have to stop because you know enough already. But if with the initial biopsies you don't get any results, so the pathologist cannot actually tell you if you have lymphovascular invasion, then you have to proceed with more biopsies. And then maybe ESD or EMR is what you could ask from your gastroenterologist to get a better specimen and then understand the biology of this disease.
And then a question to the authors of the local excision after neoadjuvant radiochemotherapy trials. What about wound healing problems? I mean, the same story was discussed in the anal cancer guideline, where we abandoned the biopsies after certain weeks after the radiation treatment. What about wound healing problems in all those studies? I couldn't read about that.
The initial studies.
Is it an issue?
Of course it is. The initial studies actually were stopped because of the healing problems. The Italian study was stopped early. It goes without saying that you have scar problems, you have bad healing, and this will affect any possibility of completion TME. So it is an issue, and it seems to me that the longer you wait after surgery, and the longer you're allowed to wait, then you will get better results in terms of healing. So if you wait long enough for a response, then we get less problems from the scar.
Are there any questions from the audience? One question towards ESD. You mentioned ESD versus local excision or tummies or TO. So ESD, if you do not reach the muscular layer.
Right.
So how to discuss with our pathologists to stay within the framework of a proper oncological resection without having the muscular layer on top of the section slice?
Well, you need to have very dedicated pathologists and a very dedicated team. So you need to have pathologists that know how to work with an ESD specimen and provide all the information on the SM layers and then tell you what, I mean, it's the same like gastric cancer. They can give you a lot of information and they don't need the muscular layer for that. If you get unfavorable histology, you know that early on before reaching the muscular. So you don't need it to be a T2 tumor. It could be a real T1, and if you get bad histology, then you proceed with other treatments. It's a matter of how dedicated your pathologist is, I suppose.
I hope he is. Okay, if there are no further questions from the audience, then I hand over to Mikola.